We can start.
Yeah, good evening, everyone. Welcome to the series, next session of core Masterclass Nephrology series. Again, we thank our conveners, Dr. P P Varma and Dr. Vijay Kher, for giving us this opportunity. Today, we welcome our expert, Dr. Prakash from Apollo Chennai, Dr. Amit Gupta, the North SCPJI, our esteemed teacher and examiner for the session, Dr. Manoj Singhal. The case being presented by Dr. Devvrat Rai from Max Hospital, Vaishali. So I request Dr. P. P. Varma to take it forward.
Good evening, ladies and gentlemen, and welcome again to this masterclass in nephrology. We all know that peritoneal dialysis is an excellent modality of dialysis, but unfortunately, it was good in horizon, but gradually it dwindled down. Possibly it is again gaining foot and is again coming up. We thought that we should cover this important modality of renal replacement therapy. So we decided just to request uh, Dr. Manoj Singhal. Professor Manoj Singhal is a very learned nephrologist, very senior nephrologist, and a respected teacher. He's director and head of nephrology at Max Super Specialty Hospital, Vaishali, Delhi. And he is passionate about peritoneal dialysis. I remember that every year, practically, he holds the class for PG students, not a class, but symposium for them, 1 day session, that and which is very well attended. And when I asked him to be examiner for this session, he was very keen. And he has brought his student, Dr. Devvrat Rai, who is again from Max Vaishali, third year student, who will be presenting the case. Today's examiner and expert are doyens in the field of nephrology. Professor Amit Gupta has been professor and head of nephrology at SDPGI and presently director and HOD at Apollo Medics Hospital, Lucknow. He is a revered figure in the field of peritoneal dialysis. If I recollect fully, in whatever the PDSI things used to come, the new guidelines and all, he always used to be a member of that. It'll be pleasure to listen to him today. And the expert for today is Professor Prakash, who is again a doyen in the field of peritoneal dialysis. And I think these few names, Dr. Prakash, Georgie, Dr. Amit Gupta, Dr. A.K. Bhalla, and these are the people who have been in the field of peritoneal dialysis. And wherever the peritoneal dialysis is today, it is a lot of contribution to that goes to these doyens, and it will be pleasure, and it will be pleasure revival of the specialty. And I was not expecting many students because even in countries like US, more than 50% of the centers don't have peritoneal dialysis. So their experience, their exposure is limited. But in India, I think it is a mandatory thing that we all should be aware of this modality, intermittent as well as CAPD, which can save many lives. My co-convener, Professor Vijay Kher, is stuck and he will be joining shortly. On his behalf and on my behalf, I welcome you all and I request Professor Manoj Singhal to start his case. And Devvrat, you can carry on and he will examining. Go ahead, please.
Good evening, everyone. So, Devvrat will present the case. This is a patient who has been on peritoneal dialysis for some time. So, there have been some problems in between during this course. So, Dr. Devvrat will highlight these problems and will present as we have managed this case throughout the last few years. So, over to you, Devvrat.
Good evening, everyone. Next slide. I'm presenting a case of a 35-year-old female. Next slide. So I'm presenting a case of a 35 years old female. She's a resident of Noida, housewife. Patient is presently a known case of CKD5 and on continuous ambulatory peritoneal dialysis. Next slide. I would like to date back my history to 2022, when the patient was diagnosed with hypertension and CKD, and she's a known case of the same since then. Her kidney biopsy was done outside in July 2022, which revealed global sclerosis in 2 out of 6 glomeruli, segmental sclerosis in 4 out of 6 glomeruli. IFTA was 30%, and immunofluorescence was suggestive of IgA nephropathy. Her serum creatinine was 5.5 in April 2023, and repeat serum creatinine levels were repeated around 10 days later, revealed the creatinine to be 11.1. In view of advanced azotemia and fluid overload, patient was initiated on maintenance hemodialysis via right jugular HD catheter in July 2023. Next slide. Can we move to the next slide, please? An option of peritoneal dialysis was also offered to the patient and an attendant, which they agreed, and laparoscopic guided CAPD catheter was placed in August 2023. She was then initiated on CAPD after 2 weeks in September 2023. Her initial PD prescription was daytime 1.5% dextrose, 2 liters, 2 exchanges, and there was a night well with 7.5% icodextrin, 2 liters. Next slide. Now, the patient in between this period presented in the OPD with uncontrolled blood pressure, weight gain, and edema, in view of which her PD prescription was changed to basically her daytime exchanges were intensified. From 1.5% dextrose, we switched to 2.5% dextrose, 2 liters, 2 exchanges. Diuretics were added in the form of toracimide 40 milligram twice daily and metolazone 5 milligram twice daily. Also, her antihypertensive medications were also escalated to the tune that she was receiving 5 group of drugs: amlodipine 10 milligram twice daily, telmisartan 80 milligram twice daily, clonidine 100 microgram thrice daily, metoprolol 50 milligram twice daily, and minoxidil 10 milligram twice a day. Now, in January 2024, due to persistent volume overload and raised blood pressure, the patient was offered to switch from peritoneal dialysis to hemodialysis. But the patient refused for the same, and her PD exchanges were continued. Her daily urine output at that time was around 600 ml per day, and her UF achieved through PD was around 1100 to 1200 ml per day, in which around 200 to 300 ml was achieved through the daytime exchanges, and around 900 to 1 liter of UF was being achieved through the night well, icodextrin. Her antihypertensive and diuretics were please stay on this slide. Her antihypertensive and diuretics was further escalated, and she was advised for strict salt and fluid restriction. Her PD prescription was also further increased to daytime exchanges 2.5% dextrose, 2 liters, 3 exchanges were advised, and night well with 7.5% icodextrin 2 liters was continued. Next slide, please. The patient was admitted in September 2024 with raised blood pressure and seizure. So MRI brain was done at that time, which was suggestive of PRES, that is posterior reversible encephalopathy syndrome, with secondary intralesional hemorrhage. Patient was, in view of poor sensorium, the patient had a prolonged stay of 20 days where she was put on mechanical ventilation and was also tracheostomized in view of prolonged need for ventilatory support. During this period, when she was admitted over here, her PD exchanges were continued. 2.5% dextrose, 2 liters, 3 exchanges in the daytime, and night well with 7.5% icodextrin, 2 liters. Upon stabilization and recovery, she was discharged with the same PD prescription. Now, upon follow-up in the OPD, her BP and weight gain was under control from this point onwards. In April 2025, patient presented in OPD with hypotension. So in view of low blood pressure, this time her antihypertensive medications were put on hold. She was advised for admission at that time and cardiac evaluation was also advised, but the patient did not agree for same and did not comply. Next slide, please. She then presented in the emergency on 9th of May 2025 with complaints of breathlessness for 2 days, nausea with repeated episodes of vomiting for 1 day, and drowsiness for 1 day. Next slide. Patient was apparently well. Coming to the history of present illness of this one, she was apparently well 2 days back when she developed breathlessness, which was sudden in onset, gradually progressive to the extent that initially breathlessness was only present on lying down, and later on breathlessness was present even in sitting position. There was associated nausea with repeated episodes of vomiting, mainly comprising of food particles. She also developed drowsiness around 5 to 6 hours prior to admission, after which patient was brought to hospital for further management. There was no history of his fever, chest pain, no cough, hemopsis, hematemesis, dysuria, no constipation, no history of any abdominal pain or tenderness. Over examination, patient was drowsy but arousable and tachypneic. There was presence of pallor and pedal edema, no icterus, cyanosis, or lymphadenopathy. A pouch containing PD catheter was seen below the umbilicus, and the exit site was facing down and laterally on the left side. There was no swelling, redness, or discharge present at the tunnel and at the exit site. Blood pressure taken in right arm supine position was 170 at 100, 170 by 100. Pulse rate was 106. SpO2 was 77% on room air, which improved to 98% after starting oxygen. Blood sugar was 136. There were bilateral fine crypts present over the bases. Abdomen was soft and non-tender. Rest of the systemic examination was unremarkable. This was the chest X-ray of the patient upon presentation to the hospital, which was suggestive of fluid overload. Next slide, please. The investigations done revealed hemoglobin 9.2, TLC 6,200, platelet 2,41,000, neutrophil 61%. Urea was 87.2, creatinine was 11.1 milligram per deciliter, sodium 131, potassium 5.2, bicarb was 22. Her liver function was unremarkable. Her IPTH was 313. Echo done during this visit revealed global hypokinesia. Her LV ejection fraction was 25 to 30% and RVSP was 45. Patient was then managed with IV diuretics, fluid restriction. Her antihypertensive medications, which was stopped initially, was started back again. Her PD prescription was optimized so that this time her daytime exchanges were increased. 2.5% dextrose, 2 liters, 4 exchanges were being carried out. And nighttime 7.5% icodextrin was continued. Next slide. Upon stabilization, she was then discharged on this following PD prescription. Her daytime exchanges were again decreased to 2.5% dextrose, 2 liters, 3 exchanges, and nighttime exchange with 7.5% icodextrin was continued. And then upcoming follow-up to the OPD, the patient was doing well. So to summarize, we have a 35 years old female, known case of hypertension, CKD secondary to IgA nephropathy, was initiated on HD in July 2023, and then switched to PD in September 2023 as per patient's preference. During her subsequent visits, subsequent years, she had repeated admissions with uncontrolled blood pressure and volume overload, requiring optimization of PD exchanges and optimization of BP medications. Her daily urine output was around 600 ml per day, and US achieved through PD was around 1100 to 1200 ml per day. There was a history of admission in September 2024 with breast requiring ventilatory support and tracheostomy. In May, she again had to be admitted. She got admitted again with acute LVF, where ejection fraction also dropped to 25 to 30%. a number of rapid exchanges are increased at that time, following which the patient symptomatically improved and was ultimately discharged. So,
So, Dr. Devvrat, I think I should thank you for this excellent presentation. You have summarized this patient well. There are a couple of issues which have come up during this presentation, which I want you to clarify. So I think the diagnosis was quite clear that patient had biopsy-proven IgA nephropathy, and she gradually progressed to advanced renal failure, and that's when she presented to us in April 2023. And this is the time she already requires dialysis, and she was started on initially hemo and then PD. So whenever you see these patients who present with advanced renal failure, how do you decide about the modality of renal replacement therapy? How do you counsel these patients which therapy is better for these patients, a particular patient?
so we offer both modalities to the patient. Like we advise for both HT and peritoneal dialysis. We give the option for both, and we let the patient decide. But we also, at the same time, assess if the patient is suitable for peritoneal dialysis or not. Like we can assess if the patient is coming from a remote area or a far area, and we can offer such patients peritoneal dialysis. Then if we have to assess the patient, like patient is physically and mentally capable to carry out peritoneal dialysis. If not so, if there is any suitable assistant uh, helper or suitable assistant present at home who can do such exchanges. So we also assess the comorbidities of the patient, like patient with multiple comorbidities, like with CAD, stroke, CLD. These patients usually don't do well on peritoneal dialysis. So if there are multiple comorbidities present, so we don't offer PD as a first choice to the patient. We offer both modalities to the patient, and we ultimately let the patient choose what he or she desires.
Do
So
you think this patient is the optimum choice for PD? PD is the optimum choice for this patient. This patient had a urine output of 600 ml per day. With
So,
PD, you are taking out almost 1200 ml is the output from PD effluent. So
yes, sir.
1800 ml is the urine output from this patient. Despite that, patient has required 5 or 6 hospitalizations in the last 2 years. Your comment first.
So this patient was having a good residual kidney function. So that is why she was offered peritoneal dialysis, and her ultrafiltration was through the day exchanges was not significant. Mainly, she was achieving ultrafiltration through the night well, through the nighttime exchanges. So, judging by this,
I think uh,
we'll have to.
Can I ask a question, please?
yes,
Definitely.
Okay. Dr. Devvrat, it was really a good presentation. There is no doubt. There are certain points which are missing, which I want to know from you. Do you think this patient has been adequately investigated after initiation of CAPD?
So, at the time when the patient was initially presented to us, when we started hemodialysis, she was evaluated. Her cardiac evaluation was also done. She was thoroughly investigated in the beginning. And
uh,
Are there
once,
any investigations pending? Though there is definitely argument going on, but most of them happen. Adopted. Is there any investigation after initiation of PD you do, which is
so
the PET,
probably you would have
PET,
done it? You are hiding from us, probably.
no.
the PET
PET. Okay.
peritoneal.
PET. And then what else? Because there is one point you have pointed out which we are forgetting. One
Yeah.
thing which I was looking into. One is PET. Then what else is missing?
Sir, evaluating that patient is compliant to the PD
No,
prescription,
that's
to the
fair
salt
enough.
and
I'm
guide.
quite sure you guys will be much more strict in that. But what else
Yes.
have you missed it?
The residual renal clearance, probably.
No, the thing is, see, you showed a value where the creatinine on full five exchanges, his creatinine was 11 or 12, and the patient is a lady. So obviously that indirectly points us either the patient is not doing well with your prescription or the PD prescription is under means is not proper. This one. I'm not criticizing anyone. Please don't mistake me. I never criticize. I'm in fact scared of P P Varma. So
Ah,
I don't criticize. Now, either of these two. The other point which comes into my mind is when we do a creatinine clearance, always it is mandatory to do a PET first, and based on the PET finding, you do the creatinine clearance. I give an example. Suppose you do creatinine clearance in a high average patient of 24-hour exchange, you will not get a good clearance because they reabsorb fast. So you have to do first define it, and based on the PET prescription, you do the creatinine clearance. That's what I thought was mandatory, and that would have helped. This patient apparently each time she has got admitted with fluid overload, hypertension, 4 or 5 admissions, if I am not mistaken. So that's one thing which I thought. Comment, please.
So, Dr. Devvrat, so what is the importance of PET in such situations? So, what Dr. Prakash has raised. So, was the PET done, or if it is not done, then is there any explanation why the PET was not done?
The PET, we usually in the current practice, we usually don't do PET because our PD, but we mainly focus upon goal directed PD, and our PD prescription and PD exchanges are guided more by the clinic, by assessing the clinical features and presentation of the patient. Like our aim is to keep the patient euvolemic, free of uremic symptoms, and it has we have evolved from chasing KT by V values to more of a goal directed PD to keep the patient.
But I think what Dr. Prakash is saying, ideally, yes, one should know the membrane characteristic of a patient, particular patient, and then optimize the prescription, PD prescription, based on their peritoneal membrane characteristic. But there is some school of thought where people believe that you can look at the daily intake output and the outflow from peritoneal dialysis. That also gives some idea about the peritoneal membrane characteristics. So what people say is that patient does his PET every day, and that can also help you to decide whether he is getting adequate dialysis or not. So I think that is the reason probably the PET was not done in this patient, and we just looked at the inflow and outflow of the peritoneal dialysis chart, and based on that, her treatment was optimized. Right?
Okay, Dr. Devrat, what do you know about sodium sieving?
The sodium sieving is basically initially when there's an initial fall in the peritoneal fluid sodium levels,
Always,
because so initially it does fall because water
always.
moves. So depending if
Yeah, that's
the
what. In
Depending
which
on what?
if like patient has got ultrafiltration failure, there is aquaporin channel defect, so
So it is
sodium sieving will not happen.
seen with higher concentration dextrose. So when you use a PD fluid with a higher dextrose concentration, that exerts a lot of osmotic pressure, and that leads to movement of water
Water.
from blood compartment to peritoneal fluid without salt. So this movement occurs through aquaporin water channels, and this pure water or electrolyte free water movement will dilute peritoneal fluid sodium concentration. So in initial 1 hour, there is a dip in the peritoneal fluid sodium concentration. And gradually the salt will also move through small pores and the salt content will rise in the peritoneal fluid. So that's called sodium sieving, usually seen with higher dextrose concentration. You may not see it with a lower dextrose, say 1.5% dextrose bag. And that indicates the aquaporin function. So how good are aquaporins working in this particular patient?
This patient, you used icodextrin freely. That is every day for 7 days a week.
Yes, sir.
Yes.
Okay. Now, when you use that, what were you watching for? Is it a safe drug or safe fluid, whatever you call it? Is it a safe, or you have to watch for certain things?
So if we are using icodextrin, like if the patient also happens to be a diabetic, we need to make sure that, because the blood, it hampers with the blood sugar monitoring. So
Correct.
we may have to like use a different glucometer to assess blood sugar levels if the patient also happens to be a diabetic. Then on long-term use of icodextrin can result in eosinophilic peritonitis. So also, like if such patients happen to develop pancreatitis, so because they may have raised amylase levels, so we use lipase for the assessment of, for the diagnosis, making
That
diagnosis
is
of
true for
acute
any
pancreatitis.
peritonitis. So that pancreatitis is a differentiation from any peritonitis. But what is specific for icodextrin? So how much is the protein loss during peritoneal dialysis? Is there some amino acid protein loss or there is
So
none?
yes, 3 to 4 grams is lost.
Is it more with icodextrin as compared to dextrose fluid?
So, yes, so protein loss may be more.
So in fact, with more convective flow, there is increased protein loss or amino acids lost in the peritoneal fluid. So initially when icodextrin was launched, it was advised to do one amino acid exchange as well to maintain their nitrogen balance. So if you're using icodextrin, you can use one bag of icodextrin and at least 1 out of 3 bags of amino acid instead of glucose. So that will give more amino acid to the patient and patient will not go into negative nitrogen balance. That's another.
Doctor, would the ladies be very happy with icodextrin going for swimming?
Sorry, sir, I didn't get it.
Sir, I did not
Will the
understand.
ladies be very
Yeah.
happy with the usage of icodextrin, but they're all swimmers going to swimming pool daily? They develop rashes
Yeah, at times.
around the panty line. So that looks abnormal, really. Those who develop rashes will look abnormal. They object. This is seen mainly in Western countries.
Yes.
Somehow here, I don't know how many are using and how many would prefer going to swim or something like that. That's one more complication.
Yeah. But I give compliment to the treating team that the patient had a albumin of 4.5 grams.
Yeah.
Despite all that, the nutrition of the patient was well looked after. My compliments. Devvrat, now you tell us the fundamental problem in this patient is fluid overload. Repeatedly, how can you decrease the fluid overload or how can you increase the ultrafiltration in the patient?
So we can increase the ultrafiltration by giving high dose loop diuretics. We can give diuretics, like we can go high dose loop diuretics, and along with that we can also add metallazone if there is residual kidney function present. Then we would like to preserve the renal function by adding ACE inhibitors, ARBs. If we like, this patient was also having raised blood pressure, so blood pressure optimization should be good, and we should try to make use
How do
of.
the ASAPs increase the ultrafiltration?
So they will not increase the ultrafiltration.
That's what
They will
I'm
help in
saying. How
preserving.
to increase ultrafiltration?
So to increase the ultrafiltration, we can increase the number of short dwells.
Yeah.
We can increase the number of
So
short
either
dwells,
you decrease the dwell time or
and
increase
we
the
decrease the
number
dwell
of
time.
dwells. Anything about SGLT2 inhibitors?
So GLT2
These days, everybody
inhibitors.
is talking about SGLT2 inhibitors. Anything about that?
So they have a role in preserving the kidney function and
Keep in mind that mesothelial layer of the peritoneum has got SGLT2 receptors. So if you are giving SGLT2 inhibitors to these people, it is blocked. So that means the sugar absorption is blocked. Almost 30% of the sugar absorption will be not there. Therefore, more sugar is going to stay in the peritoneum and the ultrafiltration is going to increase. There have been studies, animal studies, which have shown it clearly that it increases. There have been human studies also. There was one, I think, sometime back, 4 cases they have documented in a small dose. They gave only 5 milligram of DAPA and they found that the ultrafiltration increases. So that is one of the modalities just for passing.
There is one important thing. See, this patient got admitted with recurrent or repeated pulmonary edema, correct? So
Yes,
you
sir.
are talking about
yes.
increasing the fluid concentration, increasing the ultrafiltration. You are talking about removal. But are you restricting the diet, like cutting down salt, cutting down liquid intake? Nowhere it was seen.
No, so strict fluid and salt restriction was being advised to the patient on every visit to the OPD and to the IPD. Whenever the patient was presenting to us, we used to insist on the fact that strict salt and fluid restriction should be there, and she should take a good high protein diet.
Dr. Devvrat, so this patient, despite having good ultrafiltration and urine output, was in persistent ECF volume overload. Okay, so what do you think was the reason for this overload?
So mostly it could be attributed to non-compliance from the
So,
part of the patient.
so
She
generally,
was
patients who are on peritoneal dialysis, they can develop fluid overload. One, if the residual renal function deteriorate. So when they start dialysis, they're making around 1.2 liters of urine. And once you start them on dialysis, their urine output goes down, but they continue to drink same amount of water and they become volume overloaded. Other problem may be ultrafiltration problem, where they cannot achieve adequate ultrafiltration to peritoneal dialysis. But the more common problem is their compliance with the dietary advice. So if they are not compliant with the advice which you are giving, they take a lot of salt and water, thinking that now they are on peritoneal dialysis, they can eat and drink anything. So that's what leads to, and that's what probably was happening in this lady. So the moment she was started on dialysis, she every time used to come with high blood pressure and volume overload, edema over feet, and that's why her diuretics were increased and her antihypertensive were increased. And the reason she was advised to switch to hemodialysis in January, not really that I wanted to switch her, but more to scare her that if she will not comply with the dietary advice, that is going to happen. And in fact, after that, she became little bit more compliant for few months, but then again she became
yes.
non-compliant and came with press in September. So I think the main problem here was non-compliance to the fluid and water, because she was achieving good ultrafiltration, urine output was good, her other metabolic parameters were well controlled. Only problem was the salt and water overload in this lady. So
The potassium level remained normal throughout.
yes, yes, sir.
There was no hypokalemia or something.
Not really. They usually had the lower sides. I mean, potassium was around 3.5 to 4 most of the time. So,
So this uncontrolled hypertension you feel was because of the indulgence in salt intake and more water.
more water.
Dr. Devrath, despite giving 5 exchanges. I think she was receiving 5 exchanges.
Yeah.
No, not,
Eventually,
not on a
eventually.
regular basis.
Eventually.
When she was in hospital, that's when we increased it to 5 exchanges.
Okay.
But at home, she was taking 4 exchanges.
Food exchanges.
So, how do you assess the adequacy, like the whether your patient is getting adequate dialysis or not getting adequate dialysis? So, how do you assess that?
So one is the we assess clinically, like presence of any signs or symptoms of fluid overload, presence of signs of features suggesting of uremia, like decrease in appetite, decrease in nausea, persistent nausea. Then we can assess the adequacy by calculating the peritoneal clearance, solute clearance. So for that we have weekly KT by V of urea and weekly creatinine clearance. Then we can look for the adequacy of fluid removal. So for that, like we need to look for the if there is any persistent weight gain of the patient, or patient is coming with raised blood pressure. So that means that the fluid removal is not adequate. And the nutritional status, we can assess the nutritional status by assessing the like build of the patient, BMI, mid-arm circumference can be taken. Then laboratory parameters can also be used, like albumin levels, blood urea nitrogen levels, transferrin levels. So they usually may help us in giving an idea about the level of nutrition of the patient.
Mhm. So, how do you measure KT upon V? For example, in this lady, let's assume, although we have not done the PET, but let's assume her D over P creatinine is 0.8. So she is high average or say high transporter. So with that, 3 exchanges per day of 2 liters each and a night exchange of 2 liters of I could extend. What is
So,
her KT upon V?
the KT for this patient, like 4 exchanges were being carried out, 2 liters each. So the total, we calculate the total dialysate which has been removed. So
Mhm.
the volume which we have infused plus the total net UF which a patient has achieved. Like
Mhm.
8 liters were being infused, and to this we also add the net ultrafiltration which has
So let's say
which
1 liter of ultrafiltration is there.
ultras. So that comes KT comes to around 9 liters
Per
and
day. Yeah.
per day. And V stands for volume of distribution. So
Mhm.
let's like suppose if the patient is a 70 kilogram patient, so
Mhm.
60% that comes to around 60%. So
Mhm.
60% of 70 will be somewhere around, so 42.
Okay.
So that's how KT
What
and
is her
V.
KT upon V then?
So it comes to around point six, point seven, point eight, sir, around point eight.
No, no. So this is daily. Say 9 liters is per day. So when you look at KT upon V in peritoneal dialysis, it's per
We'll
week.
multiply by seven, sir.
You
Weekly it was
multiply it by 7. So 9 liters into 7 will be 63 liters per
63.
week divided by volume of distribution, which is equivalent to total body water. So 42 liters. So her KT upon V will come with somewhere around 1.7 or 1. Okay. So that's her weekly KT upon V. And how do you calculate weekly creatinine clearance?
So weekly creatinine clearance, we mm,
So how do you calculate creatinine clearance in the native kidneys?
so creatinine clearance UV by P. U
UV, urine concentration of creatinine into volume divided by
volume,
plasma
plasma
concentration.
concentration of the same.
So here we are looking at dialysate, so U is replaced by D. So
Yes,
dV divided by P,
P.
or D over P multiplied by volume, right?
Yes,
So dialysate creatinine concentration divided by plasma creatinine concentration, which is D over P of creatinine. Okay, that is zero point 0.8. And the total volume in a week we just calculated as 63 liters, right? So zero point
yes, sir.
0.8 of 63 would be
Around
roughly
50,
around
50,
55
52.
Yeah,
liters.
around 50, right? So 50 liters per week will be the weekly creatinine clearance in this lady. So do you think this is adequate solute clearance? So this is a peritoneal solute clearance, right? Add on is the residual,
Residual.
so residual kidney clearance. So that will be a bonus, right? Whatever it is. So if she is getting 1.7 peritoneal urea clearance and 50 liters of peritoneal creatinine clearance, is it a good solute clearance or you're not happy with that?
So it is acceptable.
What is the target recommended?
So we keep the KT by V of urea around 1.7, and weekly creatinine clearance we keep around 60 liters.
Yeah. So that is the general recommendation for CAPD patients, right? And if the patient is anuric, even these targets are little lower because it's very difficult to achieve these targets in an anuric patient. But some of these patients will continue to do well. So there is no point chasing the same target. So people have lowered these target in anuric patients. But now
Devvrat,
I think people are
what
generally moving away from these solute clearance target alone. So in addition to solute clearance, you should look at other parameters of adequate dialysis. As you said, the nutrition is important, fluid removal is important. What is the lifestyle of the patient? Can the patient carry out with their daily activities, which they want to do otherwise? So that's what is called high quality goal directed peritoneal dialysis. So you set common goals which patient want to achieve with the help of peritoneal dialysis and try to achieve those goals rather than just achieving a target solute clearance, right?
Devvrat, the audience is asking, could APD be a better choice for this patient?
So we can use APD like it, if we increase by APD, we can have short frequent exchanges,
Yeah.
and that can help us in removing the extra ultrafiltration. That can help us in removing extra amount of fluid. So one of the options could be to switch to APD.
So if she
You are
agrees
giving
to,
to this patient so much of 2.5% glucose exchanges 4 times a day. Logically, you are putting a lot of sugar to the patient. That eventually is going to hamper the functioning of the peritoneal membrane. Your comment, Devvrat.
Uh, um, Prolonged exposure of the peritoneum to the high levels of dextrose will ultimately result
Glucose
in,
glycation products.
yes. So there will be inflammation and later on sclerosis and fibrosis. So membrane characteristics will later on change.
Yeah, like before
If
we
we,
see, you have been doing very well. But lastly, if you can just tell us what is Elixir trial? I mean, what are the new solutions which are coming to prevent this exposure to peritoneal membrane by this extra glucose? What is the newer solution coming? Which is
biocompatible PD fluids.
this is
Uh,
xylocore solution, which is nothing but carnitine plus xylitol and very little amount of glucose. The trial is ongoing. This is Elixir trial. They want to use this fluid rather than glucose. The ultrafiltration is also better and the exposure is less. We don't know the results yet. I think the trial is going to take 165 patients. They have already taken almost half of them, and the early results are pretty good. I think a lot of good work is being done in the field of peritoneal dialysis. There's a resurgence in research in the field of peritoneal dialysis, I think.
so I think just to take it further, so your blood pressure control, you said this patient has been on 5 groups of blood pressure medicines.
yes.
So do you think that was an appropriate choice or it was like some inadequate prescription for blood pressure medicine?
No, sir. She was being given adequate amount of antihypertensives.
So almost all the groups were being
Groups were
used, say
being.
amlodipine, clonidipine, and beta blockers. What is your thought about ACE-ARBs? So generally, it is said that the once patient have advanced renal failure, they have a risk of hyperkalemia, and one should be cautious while using ACE-ARBs in these patients. What is your
So, ASABs and ARBs should be used, especially in the initial part when there's a residual kidney function, because they help us to prolong the residual kidney function. It
once
helps
they
in.
become anuric?
So then also we can continue with the ACE
So
inhibitors and
then
ARBs.
they are anuric. So the risk of hyperkalemia again is
Bulimia,
gone. So if there is no
they can still
kidney,
be
no
continued.
aldosterone, no hyperkalemia, isn't it?
Have you looked into renal artery stenosis, adrenal glands? Did you do BCM for this patient to see the total body water content?
Mm.
No, this is theoretical. Please don't mistake
No, no,
me.
no.
No.
Professor Prakash is asking a very pertinent question that we have been quiet on that. She has been requiring 5 antihypertensive in good dosage, despite good ultrafiltration and urine output. Did you look for any secondary cause for this hypertension?
Mm. No, sir.
Okay.
Yeah, I think we have not looked for these things because her BP was uncontrolled only once she started on dialysis. So prior to that, she was reasonably well controlled with two antihypertensive medications. So that's the reason that we did not investigate for renal artery or say these suprarenal glands in this patient. But I think I will take from Dr. Prakash. So these are the things which one has to look at once you see patients who have difficult to control blood pressure in such situation.
I think if we are through with the Devvrat, you have done very well, very well. I think you presented very well. I think it will be time to stay online. We may ask you further questions, but I think I will request Professor Amit Gupta to have his expert lecture on CAPD now, keeping this case in mind also.
Okay, I'll just share my slides, sir. Okay. Good evening to all of you. And that was a wonderful case that Dr. Devvrat presented and Manoj discussed. And there were questions from both all three of you, KC Prakash, Manoj, as well as General Verma. So I would just take up a few points which Dr. Vijay Kher had said that at the end of the session, you need to say a few things which students can take home as messages about peritoneal dialysis. Now, this is just to give you a brief history, which sometimes occasionally people ask in exams. This is a photograph showing Robert Popovich and Jack Moncrief. Popovich was a physicist and Moncrief was the nephrologist. And these were the two gentlemen who actually designed, or you could say, clinical start of peritoneal dialysis as a modality for long-term treatment of patients with chronic kidney disease. Because they had a patient who had run out of vascular access, was waiting for a transplant, and then Popovich sort of calculated and said that if you instill 2 liters of fluid and you could bleed fluid for about 4 to 5 hours at a stretch, and then if you do 4 to 5 exchanges, you could keep the patient in a steady state. So that was way back in 1976 when they published this methodology and kept the patient alive for about 5 to 6 months before before that gentleman received a transplant. And this was the original CAPD system adopted by Moncrief. This, because the fluid was, sorry. was in glass bottles of 1 liter each. So the patient was actually bedbound, so to say. And then came Dimitrios Oriopoulos from Toronto, who actually just made this method a little better so that the patient could be ambulatory. So what he did was that he got the fluid in a plastic collapsible bag, and the patient filled in the fluid, and then he put this bag, rolled it up, kept it in his pocket, carried it out, carried the bag for the next 4 to 5 hours. And when there was time to drain it out, he just opened up this bag as a drain bag, and the fluid was drained out. So this was, and then he used a new bag, is doing the same thing. So this was a wearable or standard CAPD where the patient became ambulatory, and therefore it was called continuous ambulatory peritoneal dialysis. In India, the PT program, as you just heard, was started initiated by Georgie Abraham, and then Prakash joined in, and so did we from the north. And we first had this something known as the OSET, which was a reusable disconnect system, which was initiated by a gentleman called Bon Cristiani from Italy. And this involved putting in fluid into the it was after you had put in the fluid in the abdomen, you put in amokina. Amokina was nothing but sodium hypochlorite, and kept this set, and which could be reused for the next 3 months or so. And this amokina had to be drained out before you did the next procedure, and very often the patients forgot, and the amokina went into the abdomen and caused a lot of pain. And this oocyte had to be changed every 14 days, and the peritonitis rates was about 1 episode every 12 patient months. And then we had the Easy Y system, which was a cheaper version of the Y set. It did not have a drain bag, and the peritonitis episodes came down to 1 episode in 15 patient baths. And subsequently, we had the twin bag, which was introduced in India in 2002, which involved having a single connection, and the peritonitis rates initially were 1 episode in 19 patient months. And the procedure was you drain the fluid out, and you flush before fill, and then fill in the fluid. So the first thing was to drain the fluid out, then you flush before you fill this patient with the 2 liters of fluid. So this system is still continuing in India, and for the last 20 odd years, we are using the same double bag CAPD system. Now, the initial training determines the patient's long-term outcome. Remember that. So when you start a patient, you must emphasize on good training and for a proper length of time. Essentially, what is taught is the overview of peritoneal dialysis, aseptic technique, hand washing, steps in exchange procedures, the emergency measures for contamination, exit site care, and how the patient should take care of complications because this procedure is done at home. So the patient and all the helpers should be well trained in able to recognize that peritonitis, about fluid balance that we were discussing in this patient, about drain problems, constipation, exit site infection, fibrin, leaks, adding intraperitoneal medications. All this has to be taught to the patient. Now, Professor Singhal was talking about the adequacy targets. So what are the adequacy targets in peritoneal dialysis? As of now, in 2006, the ISPD has set guidelines. The CAPD, it's about 1.7. For APD, it's also 1.7 over of KTOV. And for the, if you calculate the creatinine clearance, for high or high average, it's about 50 liters, and so is for low or low average type, again, they've kept it as 50 liters per week. So what is the definition of adequacy? Devvrat was talking about that you need to find out, but clinically, how is the patient doing? Does the patient feel well? Is the blood pressure well controlled? What is the fluid balance? Has the patient achieved dry weight? And these days, you can take the help of a BIA to find out whether the patient has achieved dry weight that is required. Is the patient maintaining a stable body weight? Is there absence of uremic symptoms such as nausea or vomiting or anorexia or insomnia? Is the patient well nourished? Because you remember that patient loses about 5 to 8 grams of protein every day. Therefore, they maintain the daily protein intake of about a 1.2 grams per kilogram. And continuously, you must assess the appetite and the intake of protein because this requires, this is important because in order to keep the patient in good health, protein intake has to be optimum. Now, we were talking about the residual renal function, and we all know about this importance of this slide, and I wouldn't go through it. But it just suggests that the loss of residual renal function can lead to overall increase in the cardiovascular mortality and would lead to reduction of the quality of life and well-being. So we need to keep in mind about residual renal function. And it is said that peritoneal dialysis is able to preserve the residual renal function better as compared to hemodialysis. And that is one of the plus points for PD. And that is the reason why many people suggest that if a patient has residual renal function, like this patient had a urine output of 600 ml to start with, in order to preserve the residual renal function, PD would be a better choice as compared to having the patient on hemodialysis, where the loss of the residual renal function is supposedly more rapid as compared to PD. Now, there were two important landmark studies which students need to remember. One is the CANUSA study. And this CANUSA study was published way back in 1996, where they showed initially that if you are able to increase the GFR by 5 liters per week per 1.73 meters square, the relative risk of mortality could be brought down by 12% in patients. Subsequently, there was a reanalysis of the CANUSA study, and Joanne Bogdan from Toronto, when she reanalyzed the data, actually showed that it is not merely the GFR if you increase, it's the urine volume which actually helps determining the long-term outcome. And she showed that if a urine volume of 250 ml per day or greater than that, you can have to reduce the relative risk of mortality by as much as 36%. So the important point that came out from the reanalysis of the CANUSA study, that the residual renal function is extremely important for the long-term survival of these patients. And the other study that you must remember is the ADAMEX study. ADAMEX stands for the adequacy of dialysis in Mexican patients. This was done in Mexico. And they had two groups of patients. One was the control group and the other was treated group. And here, in one group, the peritoneal creatinine clearance was 46 liters. But in the treated group, they augmented the peritoneal creatinine clearance to about 57 liters. So they increased it by almost 13 liters. And what was the result? What they found was that the survival in the control group and the treated group was absolutely similar, despite the fact that the treated group of patients had an augmented peritoneal creatinine clearance, which was much higher than that of the control group. So increasing the peritoneal creatinine clearance doesn't really help as much as preserving the residual renal function. That is the major thing that this trial, ADAMEX and the CANUSA study, brought out. Now, what should be the initial PD prescription? It should be based on the patient's residual renal function, based on the patient's body size, and the initial prescription is based on the assumption that the patient's transport status is average. And generally, the baseline PET is done after 4 weeks. There was a question on the chat box which mentioned when should the PET be done? And it is usually done after 4 weeks of the initiation of the peritoneal dialysis. And that there are 4 types of peritoneal membranes, which are characterized as high transporter or high average transporter, low average transporter, the low transporter. And basically, the 4 types have different ultrafiltration profiles. So if you have a patient who is a low transporter, that is this graph with red circles in this, you can see that their net ultrafiltration with a 2.5% bag is the peak is reached at about 8 hours, and the ultrafiltration therefore continues till that length of time. On the other hand, if you have a patient with a high transporter, with this orange squares, you can see that the peak of ultrafiltration is achieved at 4 hours, and thereafter there's a dip in the ultrafiltration. So in order to know how much time that the fluid can be kept, it's important to know which type of membrane the patient has. Because in a high transporter, if you keep the fluid in for a very long period of time, you're going to have a negative ultrafiltration, which means that the patient is going to reabsorb the fluid. Whereas in a patient with a low transport status, if you keep the fluid in for a short period of time, you will not achieve or not be able to maximize the ultrafiltration that the patient can have. So if you look at what is a high or a high average as compared to low or low average, the high or the high average have a higher D by P creatinine. The low or the low average have a lower D by P creatinine. They have greater vascular surface area, the patients with the high or the high average. Those with low or the low average have a less vascular surface. These patients would equilibrate rapidly, whereas patients who have a low or the low average would equilibrate more slowly. There is more rapid absorption of glucose, which results in diminished ultrafiltration, whereas in the patients with low or the low average, they have slow absorption of glucose, therefore results in optimal ultrafiltration with long dwells. And the patients with high or the high average need shorter dwells to minimize reabsorption and maximize ultrafiltration, whereas patients who have low or the low average need longer dwells to enhance solute clearance. So if you again compare the prescription elements, the short dwell provides ultrafiltration, diffusive clearance of small solutes. Long dwell provides connective clearance of larger solutes. There are potential clinical problem in patients who are on short dwell. The sodium sieving is not too good when short dwell is too short. The long patients on long dwell optimizes sodium removal, but the potential clinical problem reabsorption of fluid, especially for high and the high average. So the CAPD daytime exchanges is about 4 to 6 hours based on lifestyle. Nighttime exchange is about 8 to 10 hours based on lifestyle. APD nighttime exchanges is usually 1.5 hours to 3 hours based on transport status, whereas the APD daytime exchanges are dependent on the transport status and the fluid collection. And if you have an anuric patient who is on peritoneal dialysis, the KDOQI guidelines suggest that the patient should be on an APD with daytime exchanges as well. So if you look at the relationship between the dwell time and the solute transfer, patients who have a high transport status have extremely good solute clearance, but the ultrafiltration is not very good, and they require short dwell. Patients with high average, they have a reasonably good solute clearance, not as good as ones who are high transporters. And the ultrafiltration is better as compared to the high transporters. And they can be kept on the typical CAPD exchange with the usual 6 to 6 hours of dwell time during the daytime and a long dwell at night. Patients with low average have the solute clearance, which is inferior to one's patients with high average. They have better ultrafiltration and be again maintained on the standard CAPD or CCPD prescription. Patients who have a low transport status, their solute clearance is poor as compared to the other three groups. But their ultrafiltration is extremely good, but particularly if you maintain them on long dwells. So always try to maximize the instilled volumes to achieve good results. So how do you decide, or how do you start off, like this patient that Dr. Singhal started? How did he start off what was the empiric initial prescription? So the initial membrane evaluation is done through the assessment of brain volume. That is what Dr. Singhal was mentioning. So if you look at the peritoneal membrane type, and we are talking about the high transporters, there are about 15% of the patients would have high transport status. And the drain volume, if you look at the drain volume which you use with a 2.5% bag, roughly about 1500 to 2000 ml. You put in 2 liters of fluid, you're getting out about 1500 to 2000 ml at the end of a uh, 4 to 6 hour dwell time. And this is a very efficient membrane. It transports solutes quickly. There's increased glucose absorption, but these patients have difficulty in achieving ultrafiltration. And again, they are importantly at a risk of low serum albumin. Serum albumin, which General Verma was talking about, which this patient had a serum albumin of 4. So these patients who are high transporters are at times in difficulty in maintaining their serum albumin. High average, about 37% of the patients are high average. They would, at the initial drain volume would be roughly 2 liters to 2.5 liters. It's an efficient membrane, transports solutes well, and ultrafilters well. A low average, which is about, again, a third of the patients would have a low average transport status. They, again, their drain volume in the initial stages could be 2.5 liters or so, or a little more than that. It's a less efficient membrane. It transports solutes slowly, but ultrafilters well. And low transport status is seen again in 15% of the patients. They have extremely good drain volumes, almost 2.6 to 3.5 liters of ultrafiltration. The membrane is inefficient, transports solutes slowly, and it is difficult to obtain creatinine clearance, particularly when no residual renal function is there. But remember, these patients, they ultrafilter well. So what are the components of prescription management? You have fixed parameters, the body size of the patient, which you can't change. The residual renal function, again, is fixed for some time, and the peritoneal membrane transport. What are the adjustable parameters? The adjustable parameters are the fill volume, the number of exchanges, the dwell time, the modality of peritoneal dialysis, the glucose concentration, and the type of solution. And as General Verma was mentioning, the glucose concentration particularly is a major problem in patients on peritoneal dialysis. Remember, 1.5% would give 75.6 millimoles per liter of glucose with an osmolarity of 345. A 2.5 would give 125. A 4.25, which is not available these days, is about 214 millimoles per liter, and the osmolarity is very high, 484. And a 7.5% that this patient was being given icodextrin has nil glucose concentration because this is a glucose polymer that is there used. And the osmolarity is 284. And remember, the blood osmolarity is 285 to 295. So the empiric adult PD prescription, if your body surface area, you keep that in mind, and the residual renal function. So this is just a rough chart, which some of you can remember. If the residual renal function is in excess of 2 ml per minute, if the BSA is less than 1.7, you can get away with doing 4 exchanges with 2 liters each. If the body surface area is in excess of that, then you'll have to increase the exchange volume to 2.5 liters. However, if the patient's residual renal function is less than 2 ml per minute, the same patient whose body surface area was less than 1.7 would now need a volume of 2.5 liters 4 times a day instead of 2 liters 4 times a day. So if the residual renal function is present, you can get away with 2 liters 4 times a day if your body surface area is less than 1.7. But if there's no residual function, then you have to increase the fill volume. And similarly, in the APD, again, if you have a patient whose residual renal function is more than 2 ml and his body surface area is less than 1.7, you can get away doing nighttime exchanges of 4 to 2 liters and 1 daytime exchange of 2 liters for 9 hours. On the other hand, if the body surface area is again less than 1.7, but there's no residual renal function or is less than 2 ml per minute, you will have to increase the fill volume of your nighttime exchange to 2.5 liters instead of 2 liters and do again 1 daytime 2 liters. So as your body surface area again increases, you will have to increase the fill volumes and the number of exchanges may need to be increased. Now remember that if you have the KTOV of 1.7 with a six, say suppose you have a patient who is about 60, 65 kg of weight, then if you can get away using 2-liter bags. If on the other hand, if this patient is above 75 kilos in weight, you will need to use a 2.5 liters bag. And for the same, to achieve a KTOV of 1.7, if you have a person who is 90 kg of weight, you may need to use a 3-liter bag to achieve a KTOV of 1.7. So the weight of the individual, which would determine the body surface area, and the residual renal function will tell you as to what should be the volume of fluid and the number of exchanges that the patient has to do in order to achieve the KTOV which has been advised by the International Society of PD. So how do we increase the clearance? That is what was being discussed by General Varma and Dr. Manoj Singhal, that how do you increase the clearance? There are 3 options: increase the dwell volume, increase the number of exchanges, increase the dialysis tonicity. But increasing the exchanges beyond 4 in a manual CAPD is less effective as the dwell time is shorter, which limits equilibration. And the patient's compliance with 5 per day is a problem. So therefore, Manoj had done this 5 exchanges during the hospital stay and then put the patient back on 4 exchanges when the patient was discharged. There are certain ways that you can increase the solute clearance. This is what a standard CAPD with 3 exchanges and a long night dwell. What you can do is that you can increase the night dwell volume in patients to achieve a greater clearance, even though you're doing 4 exchanges. And occasionally you can use a night exchange device, which you can do 3 exchanges in daytime for 15 hours, and the night exchange for 9 hours you can increase. You can do with that night exchange device, you can do 2 cycles. So these are some ways you can increase the solute clearance in patients on peritoneal on CAPD. So increasing the dwell volume is the most effective way. Diffusion gradient lasts longer. The equilibration for 2.5 liters is only slightly less with standard 2-liter volumes. And there is this concern about increasing the interperitoneal pressure, which can produce occasionally mechanical side effects like hernia. It's not a major problem, so you can do 2.5 liters. Patients who can tolerate 2 liters of fluid can also tolerate 2.5 liters of fluid. The other thing you can do is to increase the tonicity of the dialysate fluid, but remember there's concern about hyperglycemia, hyperlipidemia, weight gain, and membrane damage, and therefore it is not the first choice. What about increasing the clearance on patients who are on automated peritoneal dialysis? Again, you can have the night exchanges and you can have a day dwell. You can increase the dwell volume. You can increase the cycle time. You can increase the number of cycles and also increase the dialysis tonicity. Let us see how each one works out. Now, the ultrafiltration profile in this patient was roughly about 500 ml when he was doing these 4 exchanges a night. Now, when the tonicity or the strength of the bags, he was using, say, suppose 1.5% bags, he increased that to 2.5% bag, and he did the same number of exchanges, you could increase the ultrafiltration from 500 each day to about 800 ml over the same period of time. However, if you increase the number of cycles, suppose this patient was doing 4 exchanges at night, but now you increase this to almost 7, 8 exchanges, but without changing the tonicity, you find that the ultrafiltration is just the same. So increasing the number of exchanges with the same tonicity, with the same length of time does not really help because you're shortening the cycles and the ultrafiltration will come down. What happens if you increase the cycle time? The cycle time, which was initially 8 hours, you're increasing that to 12 hours. So if it was 8 hours, you get an ultrafiltration of 800 ml. But if you the same patient, you increase the cycle time from 8 to 12 hours, with different varieties of the peritoneal membrane, you can increase the ultrafiltration to about 1500 ml in in over 24 hours. So remember that you have to look at the membrane type. You can look at the modality of the thing. Obviously, you have to see what the patient can do and afford, and accordingly, you can change the prescription in order to achieve greater ultrafiltration and greater solute clearance. So, what are the pitfalls in prescription? Inappropriate dwell times, failure to increase dialysis dose to compensate for decline in vessel function, or there's inappropriate instilled volume. The patient may be actually, again, remember that maybe dumping or maybe infusing less. You may have advised 2 liters of fluid per exchange, but actually the patient is putting in just 1.5 or 1.7 liters because they get so-called pain after they put in a certain amount of fluid. And the other pitfalls were multiple rapid exchanges and one very long dwell. For example, you do 3 exchanges between 8 a.m. and 6 p.m., and then you do a long dwell between 6 p.m. and 8 a.m. So again, there's inequality in distribution of the exchanges, and that can lead to poor ultrafiltration. And you may have inappropriate selection of dialysate glucose concentration. Now, some important points about peritonitis and infectious complications. How do we diagnose peritonitis? Well known to all of you. Peritonitis should be diagnosed when at least 2 of the following are present. Clinical features are consistent when there's abdominal and or cloudy dialysis effluent. And the dialysis effluent white cell count in excess of 100 cells per cubic millimeter, or at least after a dwell time of at least 2 hours with more than 50% polymorphonucleosides. So earlier on, we used to say that you must have a dwell time of 4 hours, but now the ISPD guidelines suggest that you can have the minimum dwell time that is required for sending the fluid in for a cell count is at least 2 hours, and you should have more than 50% of them be polymorphonucleosides. In patients on APD, if 50%, if the cell count is more than 50% are both or polymorphonucleosides, even if the absolute white cell count is less than 100 cells per milliliter, that is again evidence of peritonitis. So in APD patients, even if your cell count is less than 100 cells, but if the type of cells are neutrophils and they're more than 50% in number of the total of the differential count, then this is considered to be peritonitis. And the third thing is the positive dialysis culture. So if you have any 2 of these 3 present, then that is diagnosed as peritonitis. A culture-negative peritonitis is defined if their clinical features are consistent with peritonitis, that is abdominal pain and cloudy dialysis effluent. The dialysis effluent white cell count is in excess of 100 cells per cubic millimeter, with more than 50% of them being neutrophils, but no organism is identified on culture of dialysis effluent. And if the catheter-related peritonitis if the peritonitis occurs in temporal conjunction within 3 months with a catheter infection, which could be either exit site or tunnel infection, or if the same organism is producing exit site infection or tunnel infection that has been isolated from the exit site and is also picked up from the effluent, or one site is sterile in the context of antibiotic exposure. What is the definition of enteric peritonitis? A peritonitis arising from an intestinal source involving processes such as inflammation, which could be an appendicitis, perforation, ischemia of the intra-abdominal organs or bowel, identification of multiple organisms, particularly both gram-positive and gram-negative, is highly suggestive of an enteric cause of peritonitis, and of course is reported in less than 20% of the cases. And delay in treatment in these patients can lead to increased morbidity and mortality, which can occur in more than 50% of the patient. And if peritonitis episode in this context is culture negative, then it is classified as enteric peritonitis rather than a culture negative peritonitis. So even though your culture is negative, but you have an intestinal source of infection, and if you find out gram-positive or gram-negative, then you can still label it as an enteric peritonitis. What are the causes of cloudy effluent? You can have cellular causes and you can have non-cellular causes. Cellular causes which whether they are predominantly neutrophils, it's a culture positive infectious peritonitis with sterile cultures, or a chemical peritonitis. If you have predominantly eosinophils, that can occur in the initial stages, the first few days, where there can be an allergic reaction to the dialysate fluid, or because of a chemical peritonitis. If you have, say, predominant monocytes, then it's basically because the sample has been taken from a dry abdomen. Red cells, of course, suggest a hemoperitoneum, and in hemoperitoneum, particularly in females in the younger age group, because it can be because of retrograde menstruation. Red cells can also be seen in patients who have malignancies. Then again, if you have a Claudia filled with non-cellular, without much of cells, it could either be because of fibrin, and you could sometimes, very rarely, see because of predominance of triglycerides, where the patient sort of has drains out a milk fluid which is milky white in appearance. And this could be also seen with calcium channel blockers or patients with lymphatic obstruction or acute pancreatitis. The most recent analysis of the PDOPS data showed that the most common causative organisms usually are gram-positive, gram-negative, or culture-negative peritonitis or polymicrobial infection and lastly fungal infection. In India, we get to see more of gram-negative organisms, maybe because of our personal hygiene not being that great. I don't want to go through the management of different forms of peritonitis, but I thought I'll just bring out a few points about fungal peritonitis, because this has got a very bad outcome. And fungal peritonitis, is immediate catheter removal when fungi are identified in the PD effluent, and this is 1C grade of recommendation. Treatment with an appropriate antifungal agent should be continued for at least 2 weeks. After the removal of the catheter, this is grade 2C, and sometimes even up to 4 weeks. And treatment failure and mortality rates of fungal peritonitis remain extremely high. It's almost as high as 50 to 90%. Although it's slightly improved with early catheter removal, and prompt empirical treatment with antifungal therapy should be initiated even based on gram state. There is insufficient data regarding the duration of the antifungal treatment, and recommendation regarding the resumption of PD has a report after a median period of 15 weeks in less than 1/3 of the cases. So the recommendation by the ISPD, fungal organism and culture, remove the PD catheter as early as possible. If you get yeast, you can use fluconazole. If the patient is resistant to fluconazole, you can use intravenous echinocandins or oral voriconazoles. If a patient has mold, which could be either aspergillus or mucormycosis, for aspergillus, you can use oral voriconazole or posaconazole or intravenous amphotericin. And for mucormycosis, of course, the choice is limited. You have IV amphotericin or posaconazole. A few words about the various definitions that we use. Medical cure, when do we call for peritonitis? Complete resolution of peritonitis together with none of the following relapses. When do we call refractory? A peritonitis episode with persistently cloudy bags or persistent dialysis effluent leukocyte count in excess of 100 cells, even after 5 days of appropriate antibiotic therapy. How do you define recurrent peritonitis? Peritonitis episode that occurs within 4 weeks of completion of therapy, a prior episode, but with a different organism. Remember, it's a different organism. And relapsing, what is relapsing? Relapsing is peritonitis episode that occurs within 4 weeks of completion of therapy of a prior episode with the same organism, or a sterile, a culture negative episode, that is a specific organism followed by the same organism, culture negative followed by a specific organism, or specific organism followed by a culture negative. So relapsing would be peritonitis episode that occurs within 4 weeks of completion of the therapy with the same organism. Recurrent is peritonitis episode that occurs within 4 weeks with a different organism. And what is a repeat? The definition of repeat is peritonitis episode that occurs more than 4 weeks after completion of therapy of a prior episode with the same organism. So repeat is after 4 weeks. The recurrent is within 4 weeks with a different organism. Relapsing is again within 4 weeks with the same organism. So how do you manage refractory? If you remove the catheter, if you have given the patient 5 days appropriate antibiotic, you can, in some instances, you find that the patient is doing better, and even if, you may not have achieved clearance, total resolution, the ISPD guideline now suggests that you can observe the patients for longer than 5 days if the PD effluent white cell count is decreasing towards normal. When you have a relapsing, recurrent, or repeat peritonitis, timely PD catheter removal is considered to be important. Simultaneous PD catheter removal and reinsertion should be considered after culture of the PD effluent has become negative and the PD effluent white cell count is below 100 in the absence of concomitant exit site or tunnel infection. So reinsertion at the time when you remove the catheter should be only done if the effluent has become negative and the cell count is less than 100. And remember that recurrent peritonitis has a worse prognosis. So recurrent peritonitis is the one which occurs within 4 weeks with different organisms, whereas the relapsing one is one that is with the same organism. So recurrent peritonitis is worse prognosis than the relapsing ones. What are the ISPD targets for various PD programs? That the peritonitis rates should be less than 0.4 episodes per year. The rates of culture negative peritonitis should be less than 15% of the total cases of peritonitis. And the percentage of patients who should remain free of peritonitis should be more than 80% of patients that you are on your program. And PD catheter insertion related peritonitis should be less than 5%. And what has been suggested is that the increased use of APD will reduce peritonitis, use of antibiotics at time of catheter insertion. PD training, as I mentioned earlier, if it is in excess of more than 6 days, reduces peritonitis rates. And the use of exit site antibiotic ointment again reduces the rates of peritonitis. So PD patients should be assessed regularly for PD procedures. Retraining can be done particularly after hospitalization or after peritonitis or catheter infection. And these, you can look at the ISPD guidelines regarding this. Antifungal prophylaxis is recommended when antibiotics are administered regardless of the indication for the antibiotic course. And the prophylactic antibiotics should be given prior to colonoscopy and invasive gynecological procedures. And the peritoneal cavity should be drained prior to these procedures. A word about wet or dry contamination. Dry contamination occurs when the PD system is closed, and wet contamination occurs during infusion of dialysis solution or when transfer set is left open, and you have leaks from the dialysis bags, leaks or break in tubing proximal to the tubing clamp. And you generally give prophylactic antibiotics only for wet contamination. This is 2D grade of recommendation. Indications for catheter removal: failure of the PD fluid to clear after 5 days of appropriate therapy, infection within 4 weeks of completion of therapy with the same organism, associated tunnel and exit site infection, fungal peritonitis, and multi-enteric organisms. General Verma, do we have some more time?
I think we will have to close, sir.
Achha, because I had a few slides on how to approach a patient to reduce.
Another 2 minutes, please.
2 minutes will not be enough anyway. Essentially, if you have a patient with ultrafiltration problem, you look at whether there's dietary indiscretion that we were talking about, whether your prescription is appropriate or the patient has a mechanical problem. And this you can do by doing a modified PET, which you can put in a 4.25% 2-liter volume, or you can use a 2.5% with 2-liter bag. And if the drain volume is less than 2400, you're using a 4.25% bag. Or if it is less than 2100, just 100, if you get less than 100 ml extra after the 2.5% bag, then this suggests that there is some ultrafiltration problem. But if your drain volume with this is more than 2.4 liters or more than 2.1 liters, that means there is some problem in the patient not doing it properly and there's non-compliance. Essentially, I think I'll jump over these slides. So if you have drain volume which is less than 2400 or less than 2100, if you're using a 2.5% bag, look at the small solute profile, look at the transport status. If the transport status is low transport, the D by P creatinine is less than 0.5, you can have disruption of the peritoneal space. If you have a high transport status where it's in excess of 0.8 to 1, then this could be because of inherent high transport status or recent peritonitis or patient being on long-term peritonitis, peritoneal dialysis. And if you're a patient who is high average or low average, this could be ultrafiltration problem because of mechanical problems, enhanced reabsorption, or aquaporin deficiency. And type 1 ultrafiltration, which is the most common type of ultrafiltration failure, rapid loss of osmotic gradient. And the hallmark is a new onset D by P creatinine of excess of 0.81 and develops after long duration of PDE, 3 years or more. And the probable mechanism is increase in effective surface area secondary to vascularity. And it's the type 2 ultrafiltration failure is associated with lesions, advanced stage of sclerosing peritonitis. You need to exclude leaks or mechanical problems, and you try and shift the patients to hemodialysis. This type 2 ultrafiltration patients have reduced solute clearance, and the pathology is related to scarring and adhesions after severe peritonitis and other intra-abdominal complications. And the most severe form may end up with encapsulating sclerosing peritoneal sclerosis, which you can see in this photograph, that there is significant peritoneal inflammatory changes. There is peritoneal thickening that you can see, peritoneal calcification, and mental fat. The outcome is not really generally very good. Type 3 or type 4, there's lymphatic or tissue reabsorption, which is assessed by disappearance of macromolecules from the peritoneal cavity, and the type 4 is because of aquaporin deficiency, assessed by the blunting of the D by P sodium. The sodium sieving effect is lost. The type 3 ultrafiltration problem of peritoneal, because of peritoneal lymphangiogenesis, is the lymphatic reabsorption. And this can be diagnosed or thought of as the failure to achieve the desired ultrafiltration with icodextrin. And generally because icodextrin reabsorbed through the lymphatics. And type 4 is because of aquaporin deficiency, because aquaporin transports water and not sodium, that leads to sodium sieving, and usually generally seen in patients who have been there for more than 4 years on PD. So I think I'll stop here because we have run out of time, and I'll stop sharing my slides so we can get back.
Thank you very much, Professor Amit Gupta.
And I would request Dr. Prakash to add in.
No, I'll go to him also. This is a masterly lecture, what you have taken. And the crux was when you ask, can I continue? I think from audience there was messages, let's continue. I mean, that is what the students have been liking about what you are talking, and we all enjoyed and learned. I'll ask Professor K.C. Prakash for his comments. And yeah, Dr. Kher has joined. After Dr. K.C. Prakash, I'll request Professor Kher to continue.
Well, Dr. Varma, one thing I'll tell you, I feel great attending this program.
Thank you so much.
The boy, the student presented the case fantastic. The teacher of that student, though not protective of the student, was behind supporting him. That's the second thing. And ultimately, Dr. Amit Gupta's lecture, he has covered totally the PD, which I think I have revised totally. So I don't have to read it again. Please let me know whenever he talks again, so I'll go and attend it. So
Come
I
on.
don't have to read.
Come on, Casey, you're pulling my legs, I guess.
No. Amit, I never pull legs. I never. So, no, it was a wonderful talk. It was a wonderful talk. You can imagine now, I've got two devils outside, my grandsons shouting and playing. Still, I didn't get tempted to go there. So obviously that adds to that. It was a fantastic talk. I appreciate it.
But what are your comments? I mean, I think you should add up something from your side
No,
regarding.
actually, I had talked during his presentation, whatever I wanted to talk about sodium sieving, about the PET test, about creatinine clearance, and diet management, and all these things. I had discussed with him during the presentation. I think, I was disturbing him more than
I
anybody.
will like to take that one minute for both of you, Dr. K.C. Prakash and Dr. Amit Gupta and Dr. Kher. How can we promote or increase the PD penetration?
The I feel, see, apart from government hospitals, government colleges, PD is not taught regularly and vigorously in private hospitals for whatever reasons. There are many reasons which all the private practitioners know. But if that is encouraged, then I think PD can penetrate. That's one thing. Second thing, it should be easily available. And third, most important, remuneration to the nephrologist is mandatory. That's what I have seen. I have seen. I'm very blunt.
Dr. Amit Gupta and Professor Kher, please.
Yeah, I think the major issue is I always refer to this article which was published from All India Institute of Medical Sciences, Delhi, where they had done a questionnaire based this thing of patients as well as nephrologists. And what they had shown that, which this article was published way back in 2002 or 2003. And what Sandeep had shown, Sandeep Mahajan was the first author. And what Sandeep had shown that almost a third of the patients were not even aware of a modality called peritoneal dialysis. These patients were on hemodialysis. They were not aware of PD. And none of the nephrologists had discussed about peritoneal dialysis as a modality of therapy with the patients when they were initiating them on treatment. Now, I think this holds true even today. Even 25 years down the line, I don't think, including myself, we discuss about PD when we tell our patients about dialysis therapy, renal replacement therapy. And unless we do that, unless we give them a positive feedback about PD, this will the problem will be there about the regrowth of PD.
Professor Kher, please.
Can I add a comment before Dr. K?
Yes.
Sorry, sir. I think I will just add to what Dr. Prakash and Dr. Gupta has said. In addition to all these factors, what is also important is the policy decision. For example, dialysis program was launched in 2016 and it was predominantly focused on hemodialysis. I have many patients who decline for PD just because it is not reimbursed. So they will have to pay from their own pocket for PD, whereas they can get a subsidized dialysis in a Ayushman Bharat scheme or by insurance. Even insurance, there is a guideline from IRDA, but still a lot of insurance companies do not reimburse for peritoneal dialysis, whereas they reimburse for OPD hemodialysis. So I think there has to be some policy decision which has to come from the government. They've launched a PD program, but still 2019 to 2025, 6 years, we have not been able to work out the logistics of PD program. Government is setting up 50-bedded hemodialysis unit in government hospital. Even today there was news in newspaper that in one of the Delhi government hospital they are setting up a dialysis unit with 55 units, whereas there is no supply of PD back to these hospitals. So I think that has to come. Somebody who is advising the government should put in a word there as well.
Whereas data from this publication of PGI Chandigarh actually has shown there are two publications of PGI Chandigarh which had initially looked at the cost of hemodialysis and they looked at compared the cost of hemodialysis per PD. And both these articles have shown that the cost of hemodialysis, if you take into all the capital expenditure, the charges for electricity, the cost of the salaries, everything else, hemodialysis is much more expensive, even in a government setup, as compared to PD.
Yeah, so that they've shown that the dialysis unit cost of hemodialysis is approximately 4,500 rupees in a government setup.
So logically, we all say that one, nephrologists themselves are at fault. The orientation to patients is not there. Patients are not aware of that. We are not teaching our students peritoneal dialysis. And logically, there has to be support from government also. Final word, you are not allowing Professor Kher to speak. Professor Kher, sir.
Yeah, no, I think I would agree with what all has been said by Dr. K.C. Prakash, Manoj, as well as Dr. Amit Gupta. But I think the reason why PD has dwindled, especially because in the government sectors itself, except for few centers of excellence like SGPGI and government institutions like, say, PGI Chandigarh, although I wouldn't say that, then K.C. Prakash, some people who were really influencing the development of peritoneal dialysis in these specific centers. Most of the centers have lacked basically because we do not provide nursing staff, independent nursing staff who have been trained into PD becomes an essential component of providing good peritoneal dialysis. I think SGPGI succeeded and Georgie succeeded and KC Prakash succeeded basically because they had good nurses also available to them. So that, and in many private institutions, when you ask for an independent nurse, you're not given that nurse because it doesn't give any income to the hospital, and usually they don't provide you those 2 3 4 because you need really good nursing staff. And I think Amit will agree with me that in IGPJ we were able to set up this department of peritoneal dialysis or division of peritoneal dialysis with Amit taking over as the lead person taking care of these patients, but the nursing staff provided the backbone of care that these patients had to undergo. They kept the patients in, and this is not what is available. And therefore, in most of the nephrology has grown over the last 30 years in the private sector, not in the government sector. And unfortunately, in the government private sector, these kind of support systems are not available. You don't have any PD programs, and students don't get trained in the PD programs. Unless we have exchange programs, PD becomes an essential component. DNB makes it essential that you must have 3 months or 6 months of training in peritoneal dialysis. You send these patients to centers where such training is available, and without this, they will not be able to go for it. Unless they get trained, I don't think we are ever going to have any good programs of peritoneal dialysis, and it is going to go down there. And I think, in addition, what Amit has said and what Manoj has also said, the government push obviously needs to be done. And although now it's been accepted that you will be paid for peritoneal dialysis also, but I think the penetration is extremely small, and there are issues with government reimbursement for peritoneal dialysis as well as insurance.
Only 1 minute.
Yes.
See, actually, the selection of patient is also a problem. They
Yes.
try to select some patient who is about to die or who has got a
That's
lot of
true.
morbidity and is about to die. There they put in a PD catheter so that the patient relations will see, they started this and the patient died. So it carries a bad name. Not that that's one question I wanted to ask the student, who are the appropriate what you call candidates for CAPD, where you can 99 or 95% guarantee that these fellows will survive longer. There are certain set of patients who do very well. That is interstitial nephritis, like patients who have good amount of urine output, not a hypertensive, good nutrition, young patients, male, they do extremely well. You can guarantee them free life and moving around. But we select old 85-year-old person, though I don't say we should not. That's a biased opinion. But I think even good selection helps, and that propagates PD better.
I think we have exceeded time. And just incidentally, I wish to inform that Armed Forces is the only organization in the country where we have got more patients on peritoneal dialysis than hemodialysis even today.
Three cheers.
Yeah.
Three cheers.
So we
Hooray.
have got, I was just writing about the nephrology armed forces. When we collected the data, the PD patients were 546, whereas the HD patients were slightly lesser than that, who were continuous. That I think it is a will of nephrologist also, which makes a difference. I can't say more than a wonderful program, and contribution by everyone was fantastic. I'll request Professor Kher to thank and close the session.
Yeah, I think Amit's lecture was very good, and I heard Devvrat only for a shorter period of time because I joined late. And but whatever I heard was, and I would agree with KC Prakash that this was one of the best lectures on peritoneal dialysis that I heard. I've heard Amit many times, but this seemed to be the best one, which had summarized all his life's experiences as well as the way he had presented is very, very good. But I can say now that I reminded KC Prakash, I used to say that this was second grade treatment given by third grade nephrologists. Now I can say for sure that this is a first grade treatment given by the first grade nephrologists in the country. Persons who are doing only hemodialysis are second grade and third grade nephrologists and a second grade therapy. PD is definitely something that we need to grow, and I feel ashamed as being part of a fraternity where peritoneal dialysis is somehow not uh, picked up to the extent that the modality provides to the patients. And especially, I think at the moment it becomes like what KC Prakash was saying, that you pick up this as a modality of treatment for people who are likely not to do well in overall survival, or overall the outcomes are going to be poor, then this obviously is a negative thing for the peritoneal dialysis. So I think as a PD first policy, I think the country should have adopted PD first policy when the government was. And I think the experts who advised the government should have advised them that, like many other countries, PD should be the first modality of treatment when the residual renal function is good. And then we could go on to hemodialysis, or and then use it as a bridge for transplantation as well. And I think with this, I think the session was very good. Thank you, Devvrat and Dr. KC Prakash, Dr. Amit Gupta, and Dr. Manoj Singhal. And I, on behalf, along with General Verma, would like to thank Steadfast as well as all the attendees who came and attended this session. I'm sure they would have been finding it very useful to them, because these lectures are usually not as well attended as well as not provided also. Thank you. Thank you, everyone, and good
Thank you
night.
very much.
Bye-bye. Thank
Good.
you.
Thank you. Thank you, sir.
Bye-bye.
Good night.
Thank you so much,
Thank
sir,
you.
for giving us this opportunity, and thank you for faculty for such an exhaustive, learning, wonderful session. Thank you and good
Thank
night.
you.
Thank you.
Thank you. Bye-bye.
Hello. Sir, हाँ, just ended, sir. Right, से नीचे आ रहा है, right.